All right, good evening, everyone. My name is Christina Jovanik, and I'm here on behalf of Oakville Hospital Foundation and Halton Healthcare. Thank you so much for being with us here tonight for Corelife's Women's Health webinar, How to Safely Get Active with Pelvic Organ Prolapse. Our friends at Corelife Wellness have created this webinar wellness series to support women's health and to get everyone ready for our upcoming charity event, the Run for Women by Shoppers Drug Mart. This year, Corelife Wellness has taken the pledge and partnered with Halton Healthcare as a local sponsor of the Run for Women event on May 28th at Bronte Creek Provincial Park. Over the last 10 years, there have been a significant increase in the rate of ED visits and hospitalizations for mental illness in Halton. Women represent approximately 60% of visits to the ED at Halton Healthcare for mental health or substance use concern. Of those visits, women between the ages of 18 to 24 represent the largest age group using our services, and women over the age of 86 plus are the second largest. I would love for you to consider taking the pledge like Corelife Wellness has taken to walk or run for women's mental health. With your support through the Run for Women event, Halton Healthcare will improve the supports for women and girls in crisis, create holistic, multi-generational programs, and enhance the capacity of our community-based services. You can find out more about this event at therunforwomen.ca. So for tonight's webinar, you will be reviewing how to safely get active with pelvic organ prolapse, discuss the tools that can be used to provide extra support for pelvic organs, and you will learn the best strategies to optimize pelvic health when being active with our guest speaker, Gerda. Gerda holds a distinction in the degree of Bachelor of Science in Physiotherapy. She has held numerous leadership titles and is currently rostered with the College of Physiotherapists of Ontario to perform internal pelvic exams and is a member of the Women's Health Division with the Canadian Physiotherapy Association. She has always been passionate about all aspects of women's health and healthcare. Her holistic approach ensures that she always addresses any underlying issues and strives to always see the bigger picture. Her thorough, insightful, and effective assessment enables the development of an integrated and comprehensive client-centered treatment strategy. Without further ado, here is Gerda.
Hi. Hi, thank you so much for that warm welcome. I am so excited to share this presentation with you. When Brittany reached out to me, I was like, yes, yes, yes. I work in a perinatal care facility called The World of My Baby in Burlington, Ontario. And I really see women across the entire spectrum, from all walks of life, from their pregnancy and fertility journey to the postpartum phase, and then right through the perimenopausal stage of life. So I see, I see a lot of prolapse. I see a lot of complaints around prolapse. So I really am so excited to share some knowledge with you ladies. To anyone who's catching the replay, thank you so much for tuning in. And I really just want to take the time to bust some myths, debunk some kind of ideas around prolapse that I commonly come across in my practice. And then really, like Christina mentioned, just that holistic approach to how do we optimize our health once we feel that there's a prolapse somewhere on the horizon. So without further ado, I'm going to get into this presentation. Right, let's see. I need to move my screen along. So let's see how we are. There we go. Okay, let me go back. Pelvic organ prolapse, how to safely get active with pelvic organ prolapse, an overview of current management. Right, okay. I'm going to take the time to really get into our anatomical understanding of prolapse, because I think this will inform a lot around how we view prolapses, because the biggest concern that women share with me is that they feel broken, and that's quite a fear-inducing topic. So I want to really take the time to get that out of the way. On the left side of your screen, you will see the anatomical understanding that has really shaped our ideas around prolapse. And that is that we are essentially a bunch of building blocks or bones stacked one on top of the other, with the organs sort of stuck into the bits, the spaces, and then connective tissue and muscles attaching to these bones and acting like pulleys and levers, and our skin sort of draped over this framework, okay? And in this kind of understanding, it is a very linear up and down movement that we encounter. So if anything is out of place or we perceive things to have shifted, it is always downwards, sort of in line with gravity, okay? So there's that analogy of building bricks, and then also above there's, and this is how I was taught, that our pelvic organs are essentially the ship that rests in a harbor, a stone harbor, and that is our pelvis. And then there are ligaments that support the ship and keep it central, and that the muscles represent the water and they balance our organs. And what we have now started thinking about, probably in the past 50 years, is this tensegrity model, where our bones are actually the struts. They are still rigid, but they are suspended within our connective tissue, our muscular, our elastic elements. So the stringy bits in that model are the connective tissue. And so we are self-supported, we are self-suspended within this model. And what that really means is that organ movement or any kind of movement can be multi-directional, okay? And so rather than things falling down or collapsing, there is a shifting or a pulling that can happen, okay? So prolapse, let's just categorize some of the movements that can happen within the pelvis. On the top left, you have what is considered a normal anatomy. So the bladder situated to the front, behind it is the vagina and the uterus, and then at the back is the rectum. A cystocele then is a movement, a pulling of the bladder into the vaginal canal, because remember, these are very, especially the vagina, an incredibly muscular organ. It can fit a tampon or a penis or a baby's head. So there's a lot of elasticity. So if there's any pull or movement of organs, they tend to move into areas of least resistance. And this vaginal wall that is so elastic is one of those areas. So the bladder can lean into the vagina. On the top right, we have a rectocele, and that is when the rectum leans into the vagina. Bottom left is a uterine descent, so when the womb moves. Middle bottom, we have the anatomy of a woman who's had a hysterectomy. And then on the right, bottom right, if that vaginal vault, so where that cervix used to be, when that moves and shifts, we can see some movement with that too. Okay. By the way, Brittany is going to be handling the chat. Please feel free to ask questions, comment. I think she'll collate those questions, and then we can possibly discuss those at the end of this session. Okay. So the risk factors for prolapse then are, on the acute side, the pelvic trauma often sustained during birth, with prolonged second stage labor being one of those risk factors, as well as forceps and episiotomy use. I'm sorry, this slide, I had adjusted it just before we started, and I see some things have scooted on to where they shouldn't be. So pelvic floor trauma is prolonged second stage labor and forceps and episiotomy, where the more persistent chronic kind of risk factors are repeated straining, and that can be cumulative breath holding, repeated heavy lifting. Straining with toileting is one of the biggest ones. So constipation is always on my radar, and then persistent cough, either due to smoking or allergies or any kind of respiratory issues. But I'm talking years of coughing rather than just the flu or COVID. Okay. So the symptoms that women come in to see me with are a sense of heaviness, especially towards the end of the day, something bulging or protruding that they can see or feel when they are wiping or in the shower, the idea that they are sitting on a ball or on an egg or on something. Incomplete emptying of the bladder or rectum is often also mentioned, and difficulty actually initiating urination. On a sort of more lower level scale, if women come in and say something doesn't feel right, that to me is a flag that I need to have a look and see what is going on. Okay. Prevalence. The literature varies hugely on this, and there's a few reasons why. But the idea is that up to 1 in 2 women, so 50% of women over the age of 50 that have had a vaginal birth will complain of a prolapse. That number is much higher, I find, in the initial postpartum phase, but only 15% of women that are symptomatic then are symptomatic, 2 decades after they've had their babies. And the prevalence depends on the threshold of the clinician. So your GP, your midwife, your OBGYN, your PT may or may not alert you to some tissue changes and to prolapse, depending on what they are comfortable with, what they see on a daily basis, and also just because grading of prolapses is coming more and more into question in the literature. Okay. What I find a lot more important is the degree of bother, simply because it is inconceivable that the vagina will remain unchanged by childbirth. It is that elastic. So if there are tissue changes that happen, and they do happen with pregnancy and with birth, then prolapse sort of goes hand in hand with that. And the degree of bother and impact on your life and your lifestyle, I would argue, is of more significance than a measurable sort of tissue movement and pull that we can measure. So degree of bother, we can do that with questionnaires. There's a whole range of factors. I often just ask, on a scale of 1 to 10, how much does this bother you? And then improvements, I will keep coming back to that scale to assess the degree of improvement. So let's talk management. Okay. Modifying your risk factors. So if you have had a baby, but you've fallen pregnant again, or of a friend or a colleague, seeing a pelvic floor physiotherapist and just getting some information about how to optimize your birth outcomes, I would argue is a really massive step forward in just understanding how we can properly manage prolapse. Addressing these tissue changes. So with this sort of tensegrity model in mind, that model that I showed with the struts and the those strings that are in this multi-dimensional structure, if the pelvic floor tissue has been injured, okay, remember the episiotomies or the forceps use, prolonged second stage labor, your tissue, that connective tissue, can become injured, and it heals a bit more stiffly, with a bit less resilient than the tissue that hasn't been affected. And that is literally what happens anywhere in our body. So if you've ever twisted an ankle, you can feel sort of around that ankle bone, how the tissue just feels possibly a bit gritty. It is not as stable. You might not want to run on an ankle that you've just twisted. And that same sort of approach, those same principles apply to the pelvic floor tissue. So addressing any tissue changes and any stiffness within that pelvic cavity can just allow those organs to sit more centrally again, rather than being pulled into one direction. Interestingly enough, postpartum, I often find that the bladder has deviated to the left. It's just the way babies get born. The bladder needs to move out of the way, and it sort of gets squished into the top left corner. And when those dynamic pulling mechanisms are out of whack, then we often get some vaginal sensation of something dropping or feeling displaced. So that's where I start. Supervised pelvic floor muscle training. And that is why I did not want to come here and just give a 5-step, like, this is how to get back to running after a prolapse, because it needs to be supervised and it needs to be tailored. We are looking at muscular changes in terms of synergy, coordination, symmetry, endurance, strength, the ability to relax and contract, and how quickly we can move from one state to the other there. So there are so many things to consider beyond just your Kegel. And that is where having a supervised approach is really worth it, really, really worth it. And then guidance related to intra-abdominal pressure management. I will speak about that a bit more. And then general movement strategies, because the way we move and the way we lift babies, I'm talking in the postpartum phase, and get car seats in and out of the car and strollers in and out of the car can all have a bearing on how that pelvic cavity moves and responds to pressures. And then finally, if we have exhausted options and we are just finding that there are certain often higher impact activities that are still remain uncomfortable, then we look at pessaries, and we'll talk about those too. Okay, so intra-abdominal pressure is a physics concept that really relates to any sort of muscle movement in our body generating a pressure within our abdomen. And actually, one of the movements that causes one of the greatest increases in pressure is sit to stand. And we do that a million times a day. Maybe not a million, but you know what I mean. So there's a lot of pressure that gets modulated through our abdomen. And that is the work of our core musculature, so the diaphragm at the top, the pelvic floor at the bottom, muscles along the abdominal wall in the front, and muscles along the spine at the back. And these 4 muscles have a pre-active sort of integrative role. And so if we can become aware of how our bodies and what our default setting is in managing our intra-abdominal pressure, we can then change how much force we are putting through that pelvic floor. And one of the big ones is, how do we breathe when we are exerting ourselves? So when we're lifting or pulling or pushing something, and making sure, as a general rule of thumb, that we do that on an exhale. That can be massively helpful. And then toileting, huge. It's something we should be doing every day, having a poop. So if we can optimize the toileting, which is, again, just fecal matter moving down and out, there's pressure, the pelvic floor needs to relax. So it's relatively, quite vulnerable in that seated position. So making sure that we are almost in a semi-squat. You may or may not have heard about a squatty potty, or sitting with your knees higher than your hips. That it shows that on the left picture, that just allows that rectum to straighten out. And rectum is the Latin word for straight. So we need, just a tube that is pointing downwards. And so that gravity can also just have an effect on that, and that those muscles that keep the poop in actually relax fully, and that we can have a comfortable bowel movement. So that's one of the starting points, is intra-abdominal pressure management. Okay. Next, I consider your vaginal tissue health, and this is pertinent postpartum throughout the woman's lifespan, perimenopausally, it's tissue. And just like our face changes and things are less elastic, less moist, so does our vaginal tissue. Hyaluronic acid, it's in a lot of high-end face creams, gets formulated to also be applied to the vagina, to the labia. And then vaginal estrogen, if a woman is in that menopausal stage, then vaginal estrogen can be super effective. And that becomes in Vagifem and Estring are some options over there. Okay. Right. I need to, hang on. Okay. Yes, lifestyle. That's what I wanted to get to first. And then I consider this woman who's come with these complaints and feeling that there's something going on. We look at her breath, her breathing strategies. We examine the vagina. We deal with any tissue changes or restrictions. And then I start asking about lifestyle, because we are whole women. We are not just vaginas and prolapses running around. So our lifestyle matters. What is the status of your nutrition? Because ultimately your nutrients form your anatomical building blocks, and your body is constantly aiming to repair itself. So what is available for that repair work to be done? What is the quality and the quantity of your sleep? Because again, we know that it is when we are asleep that our body heals itself, and that influences tissue repair. What movements are you doing? What is the frequency? How often? What type? What do you want to do? Do you want to get back on the trampoline? Are you an Olympic discus thrower and you're wanting to join the next summer game? Bending over a lot. So what is a movement throughout the day, and what does that look like? Okay. Social connection, we know that sort of meaning and purpose definitely plays into your energy levels and where your headspace is at. So I dig into that a bit. And then finally, what is your lived stress experience, and what are your resilience strategies? So what is your go-to to manage your stress? Because that is a modifier of your lived experience. And we all know that when we are stressed, then everything else tends to feel a bit worse. And that then ties in with the degree of bother that I was highlighting earlier. Okay, so lifestyle, and we have a long chat about that, and we make small manageable changes to really reap the benefits of all the other work that we're doing. And if all of that is just leaving you with, I'm 80% there or 90% there, but when I go to CrossFit and we do skipping, which I absolutely adore, and it just doesn't feel great, then we have a chat about pessaries. Okay, and pessaries come in sort of two main types. We have support pessaries, and those are more sort of the flatter disky ones, okay? And they are typically designed more for bladder support, I find. And then we have the space occupying ones, and the one that the arrow is pointing to is the cube. And they are really fitted by trial and error. It is ideally finding that perfect jeans for your vagina or the perfect bra. So I have some sense now that I've been fitting them for a while, what may or may not work well with you, but it is essentially a trial and error approach. I rule out any contraindications. So if there's any vaginal tissue concern around ulcerations or diabetes or bleeding or infections, I do assess the vaginal wall with the speculum. If I have any other concerns, I do refer on to a GP or an OBGYN. And then we ensure a comfortable fit with sit to standing activities, with walking, and make you go to the toilet. We do some squats, get you just to walk it up and down the corridor and really just feel that this pessary sits well. If it has been fitted correctly, you should not feel anything. And most women are really surprised by that, but I've had one fitted myself. And it's quite amazing to have that inserted and not actually feel anything. It's pretty neat. Like I said, medical clearance. I work always with a medical doctor on my pessary fitting so that we can just make sure that should anything arise, we can treat it quickly and get on top of it. And then once everything has been cleared, I order the pessary and then I check in after a month, either in person or telephonically, and then again annually. Okay, there are some complications. I come across them very seldomly, simply because I teach women to insert and remove their own pessaries. I want to give them that autonomy. I don't think they should be waiting for a healthcare professional or practitioner or a nurse to remove and insert that for them. And so the complications then that I come across are very few and far between, but they do, or they can include infections, bleeding. Incarceration means that they sort of grows into the tissue. And then migration is that it actually moves out of the vagina into the uterus, for example. But again, those are more long-term problems. So if pessaries are left in for like 3 to 6 months, I don't come across those at all. Okay. And that is really what I would love to share with you today. So I don't know, Britt, if you want to take over, and then if there are any questions, we can field them that way.
Yes, hi everyone. Thank you for joining. If anyone has any questions, feel free to pipe in now or write them in the chat. If any of you want to get in touch with Gerda or have any questions that you're not comfortable asking in front of everyone, that's okay too. You can always send Corelife an email and I can connect you with Gerda separately. But thank you so much, Gerda. That was amazing.
You're welcome. You are welcome.
All right, I think we're all good for questions. Thank you everyone so much for tuning in. Oh, 1 second. Oh, just thank yous. Gerda's, what great information. Thank you so much. Someone asked, can prolapses be reversed?
Yes, they can. I would argue though that the degree of bother to me is more important. So when I have worked on especially the postpartum ladies, and there is some tissue deviation, like I said, when that bladder has been shifted to one corner and we correct that, then I will often see that the prolapse is less significant, and that happens fairly quickly after a session. If the prolapse has been of a longer standing nature, then that sort of reversal isn't as quickly noticeable. But yes, I have seen prolapses reverse. Some have stayed the same, but women have sort of learned how to move and function with them and still return to their running or whatever exercise it is that they love doing without any kind of sensory awareness of it or symptoms.
What is the relationship of prolapse and UTI? That's a good question.
Thank you. Yes. Quite big, especially if we are talking a change in estrogen. Okay, so estrogen is what keeps our tissues plump and full and very elastic. And it is also responsible to some degree to keeping our vagina very acidic. Okay, so when women come in and there's a sort of a group of symptoms around tissue sensitivity, maybe even like an appearance of like paper cuts, penetrative pain with initial intercourse, that sort of just tissue that is tearing, and some tissue movement as well as UTIs, my radar goes to what is happening on the estrogen profiling, and can we just optimize that acidic environment so that we get less UTIs. So I think that should answer the question.
That was great, Gerda. I'll give a few more minutes just to see if any more questions come in, but these are great so far. Is there an impact with age?
Yeah, and I think as women are starting to talk more about their menopausal experiences, we are starting to become more proactive about addressing those, getting treatment more quickly, and that is both on the hormone therapy side as well as just lifestyle factors, because those definitely play into how we experience the menopause. So there is a correlation with age for sure, but I'm hoping that the more we can just get information out there and not keep it a secret and address prolapses before women come in and say that they've had this for 20 years, if we could get that time frame a bit shorter when women come and see me, I think we could do a lot more to prevent unnecessary surgeries and complications and UTIs and that whole gamut of associated sort of concerns.
I couldn't agree more.
Right?
Oh my gosh. Yes, lots of thank yous. All right, perfect. I think that's it for questions, Gerda.
Yay!
Thank you so much for your time today, and thank you everyone for tuning in. And I will send everyone who registered the recording as well, so you can tune back in and rewatch, and let us know if you have any questions.
Thank you so much.
Thanks, everyone.
Bye.
Bye.